Metastatic colorectal cancer patients can still achieve disease control and gain a survival benefit with treatments in the later line setting, but maintaining quality of life is an important factor. Keep listening to explore the considerations for treatment selection and sequencing and strategies for adverse event management to help achieve optimal outcomes for your patients. Thanks for listening to this podcast episode from Core to Ed Independent Medical Education. This episode is supported by an independent educational grant from Bayer. Today's topic is all about how we can optimize outcomes with a late-line treatment of metastatic CRC. I'm honored to introduce to you to two expert medical oncologists in the field of GI oncology. Associate Professor Gerald Prager from Austria and Dr. Victor Hugo Fonseca de Jesus from Brazil. We're very excited to listen to your discussion.
Hello and welcome to today's podcast, where we are going to discuss how we can optimize outcomes with late-line treatments in metastatic colorectal cancer. My name is Gerald Prager. I'm a medical oncologist specialized on the treatment of GI cancer. I'm working at the Medical University of Vienna in Austria. Today, I'm looking forward to discuss with you the topic of late-line treatment with my colleague, Victor Hugo Fonseca de Jesus. And I'm very happy that you join us here today. And I might ask you to introduce yourself.
Hi, Gerald. This is a great pleasure to be with you here today. So as you mentioned, my name is Victor. I'm a medical oncologist living in the southern Brazil, and I'm dedicated to the treatment of patients with gastrointestinal tumors. And I'm very looking forward to this discussion with you, Gerald.
So, Victor, if you think about late-line treatment, we have patients who went through many lines of treatments before, and so they might have faced some challenges, such as adverse events. We have to consider tumor heterogeneity, resistance towards previous treatment, maybe also ongoing adverse events. And then we have, of course, to consider other comorbidities of the patients. However, over the recent years, we have seen a lot of new developments in the treatment of later line of metastatic colorectal cancer. So new treatment options were introduced into the clinic. And this might become a little bit confusing for some of our colleagues, which would be the best option for the individual patient. So, Victor, by late-line therapy, what do you consider is the best treatment for the individual patient? What different parameters, what tumor biology, what do you take into consideration when you take your treatment decision?
So this is a very important issue now. First of all, I would like to define this issue of a later line. So many authors define later line as patients who have had progressive disease after using oxaliplatin, irinotecan, 5-fluorouracil, anti-EGFR agents in the case of RAS and BRAF wild-type tumors, and bevacizumab or any other anti-VEGF agents. So this is the patients of what we're talking about. Second, now, as we started to understand more the molecular biology of colorectal cancer, we started to identify that some subgroups of patients might benefit from targeted therapies, such as anti-HER2 therapies for patients with hyperexpression of HER2 in tumor as identified by immunohistochemistry or by FISH. Also, patients with microsatellite instability as identified by immunohistochemistry or PCR of NGS, next generation sequencing, also have a great deal of a benefit after using immunotherapy with anti-PD-1 plus or minus anti-CTLA-4 agents. In the last year was published data from the randomized trial with using KRAS G12C inhibitors, the combination of sotorasib plus panitumumab from the CodeBreak 300 trial, showing that this patient might benefit from using targeted therapies. For those patients without any targetable alteration, including another alteration that I just forgot to mention was the diffusions, such as NTRK, RAT, because we have targeted agents that work very well for this subgroup of patients. This is a very small group, but they derive a lot of benefit from these drugs. For the patients without any targetable alterations, what we have nowadays is combination of TAS, 102 plus or minus bevacizumab, regorafenib, and recently fruquintinib.
So I think this is extremely important that you were discussing also the potential molecular targets. But when we talk about later lines of treatment, most of our patients should either had already this druggable target treated in the first or second line and not in the later line. So especially when we think about microsatellite instability, I think immunotherapy has its place in first line treatment. And even if you think about the BRAF V600 mutation, I think we should know it front up as soon as possible, as these tumors are more aggressive. And we should think about the treatment specific to target the BRAF mutation in second line, although it's also approved in third line. So earlier lines of treatment. So when it comes to third line and later lines treatment, in my opinion, of course, we should appreciate the molecular profile of the individual tumor. But there are other factors to consider. On the one hand, patients went through prior lines of treatment. They might have faced toxicities like skin toxicity or hematotoxicity. And so then we have options where we can individually take a choice of treatment in the third line where we consider previous toxicities. So I can give you an example. I have patients sometimes with high-grade hematotoxicities where they need GCSF support because they have neutropenia. And so for these patients, I would consider in the third line to have a chemotherapy-free treatment. So I could choose a tyrosine kinase inhibitor like regorafenib, or in some countries already fruquintinib is available. So this would be the option for those patients. And then I have patients who went through skin toxicities due to anti-HF receptor antibodies. And they would be happy not to face another skin toxicity potential treatment in the later line. Especially, there are differences from the season. So in summer, skin toxicity might be a bigger burden for some patients than in the colder winter months. So these are aspects we consider in the later lines of treatment, because I think quality of life is indeed key for the patients. So it's not only prolonging the prognosis by increasing the overall survival, but of course to maintain the quality of life of patients. And it's extremely interesting that we have seen data from the clinical phase 3 trials that if you choose a treatment which is active and compare it to placebo or less active treatment, the more active treatment maintains the performance status, the good performance status of the patients more likely and longer than if you do just best supportive care. So it sounds paradox, but it's not. An active treatment is indeed keeping our patients in a better performance status for a longer time. So these are different aspects I consider in my patients. I don't know, Victor, whether you have different experiences or additional opinions on that?
No, I couldn't agree more. I think things you mentioned about previous hematological toxicity, patients' expectations, some of the patients that do not want to cope with a skin side effect. So many of these issues we have to understand, given the non-curable intent of treatment, that this might be very important issues for the patients. This is a very important thing. And one thing I think we forgot to mention was about Rechallenge, and Rechallenge with chemotherapy and with anti-GFR agents. Maybe we could just explore this right now. What are your thoughts about these, Gerald?
So I think with all these reintroduction and rechallenges, we have to be a bit cautious as we have more active options in later line of treatment. First of all, we have to have the definition. Reintroduction would mean that a patient has a treatment in first line and never get resistant upon treatment. And you might reintroduce the very same treatment later on. So you stop first line treatment eventually because patient want to have a treatment break. And after a few months, if there is a need to reintroduce the same treatment, you can do so. And this is working, and this might be also reflected in some guidelines. However, when we talk about rechallenging, we mean the patient is treated until progression of the disease. You eventually switch the treatment to another line of treatment and then re-challenge the first line of treatment again upon second progression of the disease. This re-challenging approach attracted some attention recently, as we have seen some intriguing and interesting trials when it comes to anti-EGFR re-challenging in patients RAS wild type who had a good response in first-line treatment. However, Victor, we have to be aware that these trials were all clinical phase 2 trials, non-randomized trials with a low level of evidence. So we haven't, for the most trials, we haven't seen overall survival data. It's a limited number of patients within these trials. And then this is a very highly selected subgroup of patients where we might consider re-challenging of anti-EGF receptor treatment. So I'm hesitating to do this re-challenging approach in most of my patients in third line. I might do it in later lines, probably with the exception if I need some shrinkage of the tumor, because this might be a benefit of a re-challenging approach in these patients, that there might be a shrinkage. But even the chance is low in these patients. And when we look in the guidelines, when we talk about re-challenging of chemotherapy, there is a very low level of evidence. So I looked it up, and the ESMO guidelines, for instance, for reintroduction re-challenging, these are level of evidence 3B or 3C. So much lower than we have other options in third line, derived from clinical phase 3 trials, as you were mentioning, like regorafenib, like trifluridine plus minus bevacizumab, or like fruquintinib, where in all these 3 options, we have a level of evidence 1. And so we have better options in third line to do a different agent treatment with a different agent when we compare it to a re-challenging approach. So this is my opinion about the re-challenging.
This is very nice you mentioned this, Gerald, because very often we find people are trying to do chemotherapy re-challenging. And I think that given the amount of active drugs that we have now in later lines, I think we have to stick to the level of evidence that we have. And the best evidence we have is for the TKIs and for the tipiracil, for the TAS 102 plus or minus BEV. So this is very important what you mentioned. This is probably left for later lines after we have exhausted all our options in terms of things that have been tried in phase 3 clinical trials.
Yeah, I think also if we talk about tolerability, we have learned to handle the treatment, to manage the adverse events, potential adverse events of the TKIs over the years. So now we have a TKI in the treatment of solid tumors almost 20 years. And when we talk about metastatic colorectal cancer, we have also learned that when we, for instance, treat patients with regorafenib, we can rapidly escalate the dosage to find the individual dosage for the patient. So if you remember the REDOSE trial, which was a randomized trial showing that if you start in week 1 with 80 milligrams of regorafenib and go to in week 2 to 120 milligrams and then eventually escalate to the full dosage, which is 160 milligrams per day in week 3 before the week 4 is off, you find very rapidly the individual dose for your patient, which is tolerated. And then if you look in the data of the REDOSE study, the primary endpoint was the number of patients going to cycle 3. And this was a positive trial with this escalation design, the REDOSE design. More patients went to more cycles of treatment. And the outcome was a secondary endpoint when it comes to overall survival. There was a clear trend towards the escalation design. And it is now reflected also in the NCCN guidelines that you can do this escalation of the dosage for your individual patient according to the REDOSE study. And this works pretty fine. So we do this in our center. So we are starting with the 2 pills in week 1, escalating into 3, and then eventually to the 4 pills per day. So we don't see high-grade toxicities anymore, or very rarely. And I think the second point is that we are focusing on the informed consenting of our patients when it comes to the management of potential adverse events. So speaking again about TKIs, then we talk to our patients about hand-foot skin reactions. what they can do against potential diarrhea, low pyramid intake, and so on. So I think as we talk today, the management of TKI is not a big problem anymore, and it's well tolerated in most of our patients. So, Victor, what is your experience? And can you tell us a little bit about toxicity of trifluridine, so TAS-102 plus or minus bevacizumab?
Yes, Gerald, I totally agree with you regarding the toxicity of regorafenib. I think that over the years, we just learned how to better deliver this treatment for our patients. And I think that very rarely we see severe toxicities nowadays, especially after the data from the redose trial. We were very comfortable with the idea of increasing the dose of the medication. So I think we're very comfortable nowadays with this approach. Regarding the trifluridine tipiracil, I think the profile of toxicity is completely different. So we mainly deal with immunologic toxicities and some nausea and diarrhea. But I think that also over the years, we have learned how to manage these toxicities. And many people at the beginning were very afraid of proceeding with treatment because of neutropenia. But I think that when we stick to the guidelines from the package insert and from the recommendation from the industry, I think that we can find it very, very easy to continue with the medication. When we add bevacizumab, we have some increase in terms of toxicity for neutropenia, for nausea and hypertension. But I think these side effects are still very manageable, as we have learned to deal with hypertension also from TKIs, and also because we developed the capability of dealing with neutropenia in many ways for postponing treatment and eventually decreasing the dose. So I think it is very, very safe, and the rates of febrile neutropenia of trifluridine tipiracil are very, very low. So I think this is manageable. One thing that I think is very important is to try to bring the patient care into the multidisciplinary collaboration, because I think other specialists might help us pretty much in this setting. And this is particularly important for patients with hand-foot skin reaction, which I think it's maybe one of the most challenging side effects from TKIs, I think, in this setting, Joe.
Yeah, absolutely. So what we have in our center, we have cancer-skilled nurse, oncology nurses who take care of adverse events, and they are very much involved. They see the patients on a regular basis. I think this is key, that we detect and can react on potentially high-grade adverse events on time, that they do not emerge. And if they do so, if the high-grade adverse event emerge, we can do a treatment break or dose de-escalation, so step down the dosage, that the patient have a good tolerability. I think this is indeed key. So, Victor, short answer, please. Who would be the ideal patient in third line? So after oxaliplatin, irinotecan, 5-FU plus antibody. So in third line, went through all these IV treatment. Whom would you give regorafenib, and what would be the patient you would give trifluridine plus bevacizumab?
I think as we don't have head-to-head comparisons, this is a difficult question to answer with a very high level of evidence. But I would say that the benefit we have from trifluridine tipiracil plus Bev is somewhat interesting, especially when we realize it was compared to trifluridine tipiracil alone. So I think this is for patients with a very good performance status, for patients with a no contraindication to any other medication. I think that this might be considered one of the standards, perhaps. Patients with a low volume of disease, especially pulmonary disease, with good performance status, I think this might be ideal patients to undergo treatment with regorafenib. I'm not saying that any other patient cannot, but I think that these patients might benefit the most. Perhaps patients with a higher volume of disease, or those who do not want to have any kind of skin toxicity, maybe they are not going to be the patients that should undergo treatment with regorafenib. I don't know, what are your thoughts on this?
I can completely agree with you. So this is a very good approach, whom you would give regorafenib or TKI. And then, of course, you might consider also the toxicity profile of the previous treatment and how the patient tolerated the previous treatments, right? We discussed this before. So what will bring us the future, Victor? What is in the pipeline which is exciting you most?
Over the past 10 years, maybe, I think we have started to understand the molecular biology of colorectal cancer to a greater extent. I think one of the big issues that we have in colon cancer, maybe it's going to be one of the next developments, is the development of anti-KRAS agents. We have seen this with the G12C, but now we know that the inhibitors against G12D are coming into the clinics. And I think the combinations of these G12D inhibitors with other medications that block the MAP kinase pathway might be very, very important. I mean, this is the single most important genetic alteration in colorectal cancer that we see in the clinic. So if we have something that is particularly active against this kind of mutation, I think this is going to change completely the landscape of treatment for patients with metastatic colorectal cancer. I don't know, what are your thoughts?
Yeah, I absolutely agree. But in the same time, we have to study the resistance upon these new drugs. We have seen this with the G12C. So there is a disease control for a few months, and then the patients become resistant upon this treatment, and we have to learn what are the resistance mechanisms to be more efficient in the future. So, but I totally agree. The RAS story is interesting. So I think it's time to sum up. So we have a lot of novel treatment options in certain later lines of treatment of metastatic colorectal cancer. Of course, we need a molecular profile, but we should have the molecular profile front up before we start systemic treatment of metastatic or non-resectable colorectal cancer. And then in third line and later lines, I think most of the patients, they either already had targeted treatment upon the molecular profile, or there is no option for targeted treatment in the later line. And for these patients, we have good options. We have TKIs like regorafenib, and in some countries already fruquintinib. And then we have the option of oral chemotherapy, which is trifluridine plus or minus bevacizumab, whereby the combination is preferred. And then for those patients who went through all these options, we might consider a rechallenging of an earlier line of treatment. So by saying this, I want to thank you, Victor, for this very interesting discussion with you. I've enjoyed it very much, and I hope we can do a podcast very soon again. Thank you.
Yes, thank you, Gerrit, for the invitation. It was a pleasure for me, and it was very fruitful for me to discuss these topics with you. Thank you.
Thank you so much for sharing your insights, Dr. Prager and Dr. Fonseca de Jesus. We've learned a lot from your discussion on optimizing outcomes with a late-line treatment of metastatic CRC. If you like this episode and want to find out more on GI oncology, then look on the Oncology Medical Conversation podcast under the account of Core2Add Medical Education for other interesting episodes. Also, don't forget to rate this episode, subscribe to our channel, or inform your colleagues about it. Thank you for listening, and see you next time. This podcast is an initiative of Core2Add and developed by GI Connect, a group of international experts working in the field of GI oncology. The views expressed are the personal opinions of the experts. They do not necessarily represent the views of the experts' organizations or the rest of the GI Connect group. For expert disclosures on any conflict of interest, please visit the Core2Add website.